Welcome to webcast 2. This is coming from San Antonio. I'm joined this evening by Rob Stein, medical oncologist from London, and Ian McPherson, medical oncologist from Glasgow. And I'm Richard Sainsbury, a breast surgeon from London. We've been asked to talk around the presentations on invasive lobular cancer and an improved understanding thereof.
This is the first of 3 interesting presentations from this afternoon aimed at improving our understanding of lobular breast cancer. This was a study by Giovanna Criollo from Memorial Sloan Kettering in New York. And what they did was aimed at doing a comprehensive molecular characterization of lobular breast cancer. So as we all know, lobular breast cancer is the second commonest subtype of breast cancer, accounting for 10 to 15% of all breast cancers. It's typically ER positive, and beyond the loss of E-cadherin, comparatively little is known about it. And so what the study aimed to do was to identify the genetic drivers of lobular breast cancer, what distinguishes it from ductal cancer, and can this information be exploited to identify new therapeutics for treating invasive lobular breast cancer. And so the study took 817 breast cancers from the Cancer Genome Atlas project, which have been sequenced completely. And amongst those 817 breast tumors, there were 127 tumors with lobular morphology, 490 classified as ductal, and 88 with mixed histology. And so these tumors were comprehensively profiled as part of the TCGA project using mutational, epigenetic, transcriptional, and proteomic data. And this study took an integrative genomic approach to analyze this data and to try and identify the genomic drivers of lobular breast cancer. The vast majority of the lobular tumors in the TCGA dataset were of the PAM50 luminal A intrinsic subtype. And in order to make appropriate comparisons between lobular and ductal cancer, the authors of this study restricted their comparison to luminal A lobular and luminal A ductal cancers. So the hallmark of lobular cancer, as I've already said, is the loss of E-cadherin. And CDH1, the gene that encodes E-cadherin, was noted to have changes in 63% of the lobular tumors that were analyzed. Additionally, the authors identified some novel lobular cancer-enriched mutations, particularly affecting P10, RUNX1, and FOXA1. There was an increased incidence of P10 inactivating events in lobular cancer. Some 13% of all lobular cancers had P10 inactivation compared to 7% in the ductal cancers. And this corresponded to altered P10 expression at the protein level, and all of these alterations were mutually exclusive with PI3 kinase mutations. So PIK3CA mutations were not seen in the presence of P10 inactivation. And it also correlated with an increase in AKT activation, which is a downstream target of PI3 kinase signaling. GATA3 signaling, which regulates epithelial cell differentiation and is a known estrogen-regulated gene, was frequently altered in ductal cancers, but much less frequently in lobular cancers. There was a higher frequency of mutation in FOXA1 in lobular cancers, affecting 9% of tumours compared to only 2% of the ductal cancers. FOXA1 is increasingly recognised as a key factor in estrogen signalling, and the significance of mutations of FOXA1 is actually unclear. But it may be that it alters the sensitivity of tumours to anti-estrogens. The authors also mentioned, although made very little of, the fact that mRNA sequence analysis from the Metabrick study, which is a separate study of some 2,000 cancers, identified 3 robust molecular subclasses of lobular cancer which had quite different gene and proteomic patterns and had different prognosis. It would have been interesting to have heard a bit more about that, but I suspect time did not allow. So their conclusions were that lobular breast cancer is significantly different in its mutational spectrum from ductal carcinoma, and in particular there's a higher rate of P10 loss and a higher rate of FOXA1 mutation, which may actually act as may allow alternative therapeutics for lobular cancers. I found this a very interesting presentation. I've always seen lobular cancer as something that was really very similar to ductal cancers in the way it behaved. It tended to be low grade. It creates difficulties for surgeons because it's less well defined. It metastasizes in a slightly odd way, but is not intrinsically different. And this study has made me reconsider that view.
Following on from the previous study, this study also looked at characterizing genomic alterations in lobular breast cancer. And this is a study from the Institute Jules Bordet in Brussels. So invasive lobular cancer is the second most common subtype of breast cancer, accounting for perhaps 10 to 15% of cases. And it's characterized really as being almost always estrogen receptor positive, usually associated with loss of E-cadherin. And there are distinct clinical features. For example, lobular cancer has a tendency to metastasize to sometimes unusual sites, such as a peritoneal cavity. So this study performed a genomic analysis in 413 patients with invasive lobular carcinoma. And this was done retrospectively on archival tissue, such that there was median follow-up of 9.8 years. And they used 2 different technologies here. Firstly, a targeted approach sequencing the exomes of 360 cancer-related genes. And in addition, they performed copy number change analysis at relatively low resolution across the genome, but in higher resolution at some hotspots. So the key findings were that on average, about 6 mutations were found across these 360 genes in each case. By far the most common gene mutated was E-cadherin, as we would expect, and this was followed by PIK3CA, PI3 kinase. In addition, there were some other interesting genes identified, so TBX3, which is a transcription factor, and also FOXA1 and GATA3, which are part of the estrogen receptor binding complex. In addition, some genes involved in chromatin remodeling were identified. At lower frequency, mutations were also observed in P53, also in AKT and PTEN. And then very interestingly, there were activating mutations identified in both HER2 and HER3. So putting this together, about 50% of tumours had activation of the PI3 kinase pathway, and about 15% activation of HER2, HER3 signalling. Moving on then to the copy number changes, and recurrent copy number changes across the cohort were identified in ESR1, the gene for estrogen receptor alpha, in MYC, cyclin D1, and insulin-like growth factor 1 receptor. And similar to the previous study, a comparison was made with invasive ductal carcinoma cases in the TCGA database. And this showed again that there was an increased incidence of FOXA1 mutations in lobular versus ductal cancer, and also that there was an increase in AKT and PTEN mutations, as well as TBX3 in lobular versus ductal carcinomas. They then looked at the implication of these various genomic changes on survival. And in terms of the oncogenic mutations in PIK3CA, PTEN, TP53, these were not individually significant. However, looking at copy number alterations, there were various amplifications or losses which were strongly associated with outcome. So, in summary, these results do give us greater insight into the genomic changes which occur preferentially in lobular breast cancer, and they raise the possibility of developing specific targeted therapies. For example, looking at the PI3 kinase pathway and looking at that subset with activating mutations in HER2 and HER3.
I've been asked to talk about the SABCS study, and which looked, or a sub-study of it, looked at luminal A and luminal B lobular cancer. And the background of this was basically put upon the overview that John Forbes presented at ASCO earlier this year of nearly 12,000 patients, showing a significant benefit for both recurrence and death for patients taking anaromatase inhibitor compared to tamoxifen. And when Big 198 was analysed, it was clear that there was no difference in disease-free survival for patients who had invasive ductal cancer, but there was an improved disease-free survival and overall survival for patients who had invasive lobular cancer, and the hazard ratios were 0.49 and 0.39 respectively. They did subset those invasive lobular cancers and found that there was no difference whether they were luminal A or luminal B, although, as expected, nearly 80% of them were luminal A cancers. So with this background, the Austrian group decided to look at, retrospectively, at their study and to see whether they could find a difference between the types of lobular cancer. They originally had 3,700 patients of moderate to intermediate risk, grades 1 to postmenopausal, none of whom received chemotherapy. They received 2 years of tamoxifen, then were randomized to either 3 years of anastrozole or a further 3 years of tamoxifen. They showed no difference in overall survival or disease-free survival for patients, whether they took the tamoxifen or the anastrozole. However, they were able to show a significant improvement for patients who had invasive lobular cancer as opposed to invasive ductal cancer. Their numbers were quite small, and this is something that we'll discuss, I'm sure, in the round table later. But by the time that they had dissected out the group of patients from their 3,700, it had dropped down to a total of 1,400, of which only 270 were invasive lobular cancers. So that something we need to discuss. When they looked overall at their results, they showed that for luminal A patients, the disease-free survival and overall survival was significantly better for patients with ductal cancers, and that 81% of their patients were luminal A. For the small group of luminal B patients, which totaled only about 26 patients, the disease-free survival and overall survival were better for lobular cancers. And again, this seems slightly counterintuitive that this would switch round, and again, something for us to discuss. So their overall conclusion was that there was a difference between luminal A and luminal B in the way that they responded to an aromatase inhibitor, and that this was worthy of further study. My critique of this presentation was that it was a subset analysis retrospectively with very small numbers. And although they reached statistical significance, I think there must be some question about the actual numbers there. The other problem was that at the time of this study, many of the patients were classified into lobular status on the original pathology, which was performed without E-cadherin staining. And so that there is a potential that some of these patients may not actually be lobular cancers. And there was no information given as to whether there was a central pathology review before they started this study. And so I think Rob's going to start by discussing his presentation. And what points would you like to bring out?
So I thought this was an interesting but very preliminary attempt at trying to establish whether lobular breast cancer really is a different entity from other forms of ER-positive breast cancer or not. So I suppose we've been taught for a long time that once you take grade into account, there really is not much difference between lobular and ductal breast cancer, apart from the fact that it causes surgeons a certain amount of difficulty, and it metastasizes in a slightly strange way. Right. And all of this is presumably explained by the lack of E-cadherin. So rather than growing in a cohesive manner, it grows in a discohesive manner because, of course, E-cadherin is the glue that holds cells together. And actually, I came away from this afternoon thinking that maybe lobular breast cancer might be slightly more different than I had previously thought.
And do you think the subtypes matter? Now with doing molecular characterization better, and one thing that came over me was, should we really be looking more closely at the difference between luminal A's, luminal B's? Do you think that's ready for clinic use?
Yes, I think the key thing in the study which Rob has discussed as well as my study, and I would look at the two of these very much together, is really that we're now drilling down in much more detail into the genetics and other features within lobular cancer. So we've done this already, for example, for so-called triple-negative breast cancer over the last few years, defining multiple subtypes within that entity. And perhaps lobular breast cancer has lagged behind a bit. It's remained a morphological diagnosis. And certainly the studies today would suggest that actually within that there are distinct disease entities characterized by perhaps different risks of relapse, different oncogenic mutations, different copy number changes, and so on.
So, are you going to go home and start ordering PAM50 on all your patients?
I think we're not quite there yet to use that as a decision-making tool.
But it's very interesting, of course, that PAM50 is now an FDA-approved test.
Right.
And so there is an FDA-approved definition of luminal A and luminal B breast cancer, which didn't previously exist. And one of the problems of I know this is an aside, but one of the problems of intrinsic subtypes has been that the definition very much depended on who was actually performing the measurements. Right. But there's now a gold standard. It's unfortunately one that's not yet readily accessible, but that may change.
Right.
And we've seen some interesting data in other studies earlier today, really about the plasticity of the phenotype, and certainly in response to treatment. Perhaps unsurprisingly, if you downgrade proliferation with effective endocrine therapy, a luminal B cancer will in fact have a luminal A gene expression phenotype. So these are not fixed in stone, rather they're a description within a moment of time.
Which again calls into question the findings of the ABCSG study, because they treated with an aromatase inhibitor and their luminal Bs you would have expected might have popped back as luminal As, and there seems to be no attempt to dissect that out. So what other messages do you want to take?
I found the ABSCG study quite disappointing. I mean, the numbers are extremely small, and it's really difficult to know how reliable that data is. And I think a meta-analysis is probably the way to go forward.
I would agree. I think by the time they've got down to the subsets with 26 patients in each arm is just not reliable enough. And there's no logical reason why it should flip from being better for luminal A in one group, or for luminal A cancers, but why ductal cancers should be better when everything else shows that the lobulars actually do better. So that I think there's more questions there raised than answered. One of the things I wondered about was the targets that there might have been identified. I mean, the first two papers identified potential genes that might be of interest, the ERB3, ERB4, and the P10. What do you feel to that? Do you think we'll be seeing druggable targets coming out from there?
Well, P10 is really part of a PI3 kinase pathway. It wouldn't be affected by PI3 kinase inhibitors as such, but the other drugs that affect the PI3 kinase pathway, so the AKT inhibitors, the TOR inhibitors, would certainly be effective in P10 mutant cancers. But of course, the study that I looked at was very much a comparison between lobular and ductal cancer. And so things that were the same, such as the PIK3CA mutations, were not particularly discussed in that presentation, which is different from the Institut Jules Bordet, who did their stamp collecting, because it is still stamp collecting, sadly, although we're beginning to build an album.
Yeah, I think that's exactly right, Robin, particularly in terms of some of these copy number changes, where it wasn't always clear perhaps what the driving event within that copy number change would be. Some of them chromosome 17 amplification, for example, with HER2, but others it was not as clear. But certainly in terms of the mutations then, as Rob said, loss of P10 may predict sensitivity to an AKT inhibitor, but clearly drugging this pathway is not as straightforward as it may at first seem. Interestingly, the HER2 mutations are those previously reported as activating mutations within the kinase domain, which have been sensitive to drugs such as neratinib, so that would be a potential line of attack there.
And the FOXA1 mutations are actually quite interesting. I don't think anybody knows what the significance of those is yet, but FOXA1 is increasingly recognized as an essential part of estrogen receptor transcriptional response, and therefore it may well alter the way in which the estrogen receptor actually behaves, both to its ligands and to anti-estrogens. But I think more research is required there.
Yeah. No, that was quite interesting, and the cartoon he produced of showing it being made much more available. So it does seem quite interesting, but the mutations seem all just to be in the fork-head domain. So again, that's interesting why they should all be concentrated there. It seemed, that there was a massive peak there and very little elsewhere in the in FOXA1. Yeah.
I think again, very interesting point, and the implications, as Rob said, are not clear, but whether some alteration in the estrogen receptor transcriptome may explain some of the findings that you've discussed in your study certainly would seem possible.
So should we consider lobular breast cancer as a fundamentally different entity to ductal cancer or not? I mean, I guess that's...
I think increasingly so. I mean, as we drill down, TNT's gone off by itself and been fertile ground for you and your colleagues, and lobular cancer, as you say, certainly causes us problems as surgeons, and its different metastatic pathways and potential and sites, which are protean. I'm not sure how that's explained by this data, but I think we should perhaps consider lobular as a different disease.